Yeah, it's a pleasure to be here, and I'm going to give a talk about asthma exacerbations. The title is Facing Asthma Exacerbations, but I'm talking about mechanisms of exacerbations and the implications that those mechanisms might have for treatment and prevention of exacerbations. So starting off, this work was done in Southampton around the time I was there with George, developing PCR for rhinoviruses and coronaviruses back in 1989-1990. And that study resulted in this figure for detection of viruses in school-aged children with wheezing episodes. 85% were virus-related, and many other studies since then have reproduced those results. And in younger children, it's around 95 to 100% of virus-related. In adults, around 80% of virus-related. And the remarkable thing about all these studies was that around 70 to 80% of the viruses detected were rhinoviruses. And what was notable about that is that rhinoviruses in healthy people cause really only upper respiratory illness with no lower respiratory illness, yet in people with asthma, you get an exacerbation of a lower respiratory illness. And so that led us to start investigating antiviral immunity in people with asthma and comparing them with healthy controls, because we hypothesized that people with asthma might have impaired antiviral immunity. And the results of those studies are summarized on this slide. The first was this one in 2005, quite a long time ago now. This and following studies identified broadly impaired innate and Th1 antiviral responses in asthma in response to rhinovirus and other respiratory viruses. We were able to show that induction of interferon alpha, interferon beta, gamma, lambda, and IL-15 were all deficient and delayed in bronchial epithelial cells, peripheral blood mononuclear cells, peripheral blood dendritic cells, and bronchoalveolar lavage cells. And this was true in both adult and pediatric asthma. Studies with Alberto Papi and colleagues in children showed that to be the case. Deficiency in several studies was related to markers of underlying asthma severity, and I'll come back to that in later slides. And we were also able to show by measuring interferon lambda, gamma, and IL-15 production in bowel cells when adults with asthma were stable, and then subsequently infecting them with a rhinovirus experimentally, we were able to show that deficiency in these responses was related to exacerbation severity following the virus infection in vivo. And further work from Jim Gurn and colleagues in children in America has also shown that low interferon responses in nasal epithelial cells and high type 2 inflammation were very strong predictors for risk of subsequent asthma exacerbations. So very clear that impaired antiviral immunity is important in asthma. And this illustrates that very nicely. This is an experimental infection study in people with asthma in red and healthy controls in black. We had 11 healthy controls, 28 people with asthma, and they were all inoculated with exactly the same dose of exactly the same virus on day 0. And we followed responses after that virus inoculation. And here we're looking at virus load in the nasal lavage, and you can see that virus load peaks earlier in people with asthma on day 3, whereas in the healthy controls, it peaks on day 4. And on day 3, the virus load is significantly greater in asthma than in healthy controls. This is a logarithmic scale, so that difference is about 250-fold. So it's a big difference. And there's also a suggestion of slower virus clearance in the virus loads later on day 7 and day 10 are higher in asthma. That results in greater upper respiratory symptoms, both an early peak being greater in asthma and again, slower clearance of symptoms in that the controls had recovered by around day 10, 11, people with asthma not yet recovered by day 14. And then in the lower respiratory tract, the differences are most dramatic in that the healthy controls have no lower respiratory symptoms of any note, but the people with asthma have a very clear episode of lower respiratory symptoms that lasts around 2 weeks. So very clear differences between people with asthma and people without asthma in response to virus infection. This is exactly the same study, but categorizing people into the healthy control group again, but the asthmatic people into those with mild asthma and those with moderate asthma. And we're looking here at the total lower respiratory symptom score over the 14 days after virus inoculation. The healthy controls have virtually no lower respiratory symptoms. Mild asthma has a symptom score of around 20 over that 2-week period, but moderate asthma is more than double that, at just over 40. So having more severe asthma puts you at risk of having more severe symptoms with a respiratory virus infection. And on the right side, we're looking at asthma control. Again, the healthies, no lower respiratory symptoms. Well-controlled asthma, a score of around 20. Partially controlled asthma, a score of around 60. And poorly controlled asthma, partially controlled, a score of around just under 40. And poorly controlled asthma, a score of over 60. So the degree of asthma control, as well as your degree of asthma severity, both influence the outcome of a respiratory virus infection. This is a study carried out with Adnan Chustovich, 2 studies, in fact, one in adults and one in children, investigating people admitted to hospital with an asthma exacerbation, and 2 control groups, one people with stable asthma in the outpatient clinic and the other people admitted to hospital for non-respiratory conditions. They were all sampled for allergen sensitization, current allergen exposure with a home visit, and virus infection with a nasal aspirate. And you can see here that if you have exposure to an allergen that you're sensitized to, your risk of an asthma admission for an exacerbation is approximately doubled. However, if you also have a virus infection at the same time as that exposure is occurring, your odds ratio is over 8. This is in the adults. In the children, the interaction was even stronger with an odds ratio of 19. And these studies show that there's very clearly a synergistic interaction between exposure to an allergen that you're sensitized to and virus infection in dramatically increasing your risk of an asthma admission. So what are the mechanisms involved? This is showing you nasal sampling with an absorptive matrix to sample airway lining fluid from the nose, which you can then elute from the matrix with a buffer, and you end up with airway lining fluid that's diluted about 1:2, whereas nasal lavage would be very much more dilute. And this is a probe going into the bronchus. You can see it here, sampling airway lining fluid from the bronchial mucosa. And again, you elute from that, and you get bronchial airway lining fluid, again diluted about 1:2, whereas bronchial lavage, again, is very, very much more dilute. And using these techniques, we were able to measure a large number of cytokines. I'm going to focus today on the type 2 cytokines, IL-4, 5, and 13, and epithelial-derived mediators that induce those cytokines, IL-25 and IL-33. We were not able to measure the third epithelial cytokine that promotes Th2 responses, TSLP, because assays measuring it were not good at the time those studies were carried out. And this is, again, the study I showed you the clinical outcomes on in the earlier slides, with the virus load and the respiratory symptoms being greater in the people with asthma. Here we're looking at nasal IL-4, nasal IL-5, and nasal IL-13. Day 0, which is the day of inoculation, you can see that type 2 cytokines are higher in people with asthma than those without, not surprisingly. However, this is the peak during infection, and this is day 42, 6 weeks later in convalescence. And you can see that there's very clear induction of IL-4 during the infection, also induction of IL-5 and induction of IL-13. So this is showing that a virus infection, which classically is thought to promote Th1 responses rather than Th2, also promotes Th2 responses. And here we're looking at bronchoalveolar lavage eosinophils, increased in asthma at baseline, not surprisingly, but again showing an induction of eosinophils in the bronchoalveolar lavage. Comparing baseline with during infection. This is a bronchoscopy carried out on day 4 following virus infection. So induction of Th2 responses does occur following a virus infection in people with asthma. That induction is related to respiratory symptoms. This is nasal IL-5 compared with lower respiratory symptom score, significant in those with asthma only, not in those healthy controls. And this is bronchial IL-13, again, low respiratory symptom score, significant in people with asthma, but not in the healthy controls, suggesting that the more Th2 cytokines you have, the worse your outcomes are going to be. So I mentioned IL-25 earlier as an epithelial-derived cytokine that promotes type 2 responses. We're looking here at a mouse model in which mice are exposed to ovalbumin in all these conditions with UV inactivated virus or live virus. And here we have an isotype control or an antibody to the IL-25 receptor. So you can see that there is an exacerbation of IL-4, IL-5, and IL-13 production in the bronchoalveolar lavage, comparing ovalbumin alone with virus plus ovalbumin. And you can also see that if you have an antibody to the IL-25 receptor, that exacerbation is suppressed back down to levels seen with allergen alone. And that's true of IL-5 and IL-13 as well as IL-4. Other outcomes associated with type 2 responses, MUC5AC protein production, also suppressed with anti-IL-25, eosinophilia suppressed, bowel lymphocytes suppressed, and on the next slide, we have bowel IL-4 positive basophils being profoundly suppressed, ILC2 cells being suppressed, and IL-4 positive, CD4 positive T cells, which will almost certainly be allergen specific, also suppressed. So in this mouse model, at least, IL-25 appears very important in virus-induced exacerbations. IL-33 is another epithelial-derived cytokine which promotes type 2 responses. This is bronchial epithelial cells infected with live rhinovirus, UV inactivated rhinovirus, or media control, showing that IL-33 is very strongly induced by virus infection in bronchial epithelial cells. This is nasal IL-33 levels in that clinical study, day 0 before infection, during infection, and convalescence, showing that there is significant induction of IL-33 in the people with asthma. There is an increase in IL-33 in the controls as well. So it may be, well, we have since shown that levels of IL-33 are greater in people with asthma than people who don't have asthma, but IL-33 is induced in the healthy controls as well. But the difference is that the people with asthma have more cells in the airway that are able to respond to IL-33 as well as producing more IL-33. So, and here showing that IL-33 is tightly correlated with type 2 responses, IL-5, IL-13, low respiratory symptom score, and virus load. We didn't have a mouse model in which we could use anti-IL-33 at that time, so we used an in vitro system here studying human T cells in the top panel, Th0 cells, in the white bars, incubated with a bronchial epithelial cell supernatant from uninfected bronchial epithelial cells in the gray bars, and in the black bars, a bronchial epithelial cell supernatant from rhinovirus infected bronchial epithelial cells, which would contain substantial amounts of IL-33, as we showed on the previous slide. And here with an anti-IL-33 receptor antibody or an isotype control. So with the isotype control, you can see that the infected bronchial epithelial cell supernatant induces high levels of IL-4, IL-5, and IL-13. However, if you have an anti-IL-33 receptor antibody in the culture, that induction does not occur. And on the bottom panel, we have exactly the same experiment, but with ILC2s purified from peripheral blood. They don't produce much IL-4, so no significant findings there. But with IL-5 and IL-13, again, very strong induction with the virus-infected bronchial epithelial cell supernatant and complete absence of that induction if you have an antibody to the IL-33 receptor. And note that the concentrations of IL-5 and IL-13 with the ILC2s are very much higher, in the thousands of picograms, compared to the Th0 cells, where they're in the hundreds of picograms. So ILC2s are very potent producers of type 2 responses in response to IL-33 when you have a virus-infected bronchial epithelial cell supernatant in the culture. So in this system, it appears IL-33 is vital. We'll come on to those cytokines again later when we consider therapy. This is a study published recently, just earlier this month in the Blue Journal, investigating whether ILC2s are increased in asthma and whether they increase with virus infection, because we just showed on the previous slide that they're potent producers of type 2 cytokines. It's a study, again, experimental infection with rhinovirus, 12 healthy controls and 11 people with asthma successfully infected. And we carried out a bronchoscopy at baseline around 2 weeks before they were inoculated with virus on day 0. And we did 2 bronchoscopies on this occasion. The previous study, it was on day 4. Here we looked at on day 3 for early responses and on day 8 for later responses. And we measured ILC2s by flow cytometry. These are the markers. I won't go through them because of time. We also looked at ILC1s, and that's the lineage negative cocktail for you. In this study, we also showed that virus load was increased in people with asthma. It peaked on day 4 in this group, but was significantly greater in the people with asthma than the healthy controls. And here we showed that there was a significant relationship between asthma control prior to infection and the virus load during infection, again emphasizing that if your asthma is poorly controlled, you'll have a very much worse response to infection than if your asthma is well controlled. These are the ILC counts in the bowel, baseline day 3 and day 8, ILC2s here, ILC1s here, and the ratio here. Interestingly, ILC2s went up in the healthy controls on day 3. They went up a bit later in the people with asthma on day 8 and were significantly increased in asthma compared with healthy controls, both at baseline and on day 8. ILC1s again went up early in the healthy controls and later in the people with asthma. And looking at the ratio here, you can see that in the healthy controls, the ILC1s always outnumber the ILC2s in the healthy controls, and the ratio is always less than 1. Whereas in the people with asthma, there are some people with considerably more ILC2s than ILC1s at all time points during infection. And again, correlations between type 2 cytokines and rhinovirus infection. And here, many relationships between the ILC2 ratio and type 2 responses, symptom severity, not virus load in this instance. This is ILC2 ratio at baseline. This is ILC2 ratio on day 3. And this is ILC2 ratio on day 8. Suggesting that the more ILC2s you have, the worse the outcomes are. So what are the implications of all this for asthma exacerbation treatment or prevention? We now have many clinical studies. This is one of the earlier ones investigating mepolizumab, showing that there's about a 50% reduction in exacerbation frequency compared with placebo. That has been shown for anti-IL-5 treatment, anti-IL-5 receptor treatment, anti-IL-4/13 receptor treatment, anti-TSLP, and anti-IL-33. They all reduce exacerbations by 40, 50, 60%, depending on the different studies. What's interesting, though, is that the major effect in nearly all these studies is on exacerbation frequency, but very little effect on lung function. And that suggests that since most exacerbations are virus-induced, it's highly likely that anti-type 2 therapies boost antiviral immunity, and that's something that I think needs to be studied. It has been studied with omalizumab, as I'll show you in a moment. This is a study with inner city youths with asthma who were treated with omalizumab or placebo for 4 to 6 weeks prior to the return to school in the autumn. Treatment was associated with a 50% reduction in exacerbations, as has been shown previously. 89% of the exacerbations were viral, and 91% of the viruses detected were rhinoviruses. Cross-linking the IgE receptor in PBMCs suppressed interferon gamma production, as has been shown previously, and that was restored by omalizumab treatment. And we're looking here on this graph at the degree of restoration of interferon responses compared with baseline. Those that had an interferon response restoration that was greater than the median had almost no exacerbations. Those that had an interferon restoration that was below the median had a much higher rate of exacerbations. So the greater the degree of interferon restoration, the greater your protection from exacerbations. That clearly shows that this therapy restores antiviral immunity, and we would like to study the other anti-type 2 therapies as well. Other possible treatments, giving interferon. This was a study investigating inhaled interferon in people with both mild and moderate asthma. This is looking at data in only those with moderate asthma, showing that there was significant protection with inhaled interferon, and that those taking inhaled interferon did not have a significant worsening in their ACQ score, whereas those on placebo did. And here showing that there's an improvement in peak flow with active treatment, where there's a deterioration with placebo. This was a study carried out by AstraZeneca investigating only people with GINA 4-5, so moderate to severe asthma. 121 subjects randomized. They didn't get many severe exacerbations, which was the primary outcome, so that endpoint was not met. And the study was stopped early because they were not getting enough severe exacerbations. However, they did reproduce the finding that there was an improvement in peak flow overall, and especially so in those who were virus positive or who had high eosinophils at baseline, with a 56 liter a minute improvement. And here showing that interferon beta in a different virus infection in COVID-19 is very highly effective at improving symptoms and clearing virus. So final data slide is azithromycin, which we showed a number of years ago, increases interferon responses in bronchial epithelial cells, dose-responsive increase in interferon beta and interferon lambda here, and here showing that it's antiviral. And here the clinical study from Peter Gibson showing that azithromycin given for a year prophylactically reduces exacerbation frequency by about 40%. And I'm sure that that's largely due to its antiviral interferon-inducing properties. So conclusions are that virus infections are the most common cause of asthma attacks. Rhinoviruses cause the majority. New approaches to treatment and prevention are needed. There is deficient antiviral immunity in many people with asthma, especially those who are more severe and with less good asthma control, and thus boosting innate antiviral immunity is likely to be effective. Allergens and viruses synergize an increasing risk of exacerbation. There are increased type 2 responses in the lung in asthma with virus infection. IL-2s are also increased and are further increased during infection. Anti-type 2 therapies all reduce exacerbations substantially, and interferons and interferon-inducing agents like azithromycin are also likely to be effective. So thank you very much for your attention. I'm very happy to take questions.